achieving the 0-degree knee extension on a flat surface. It is isometric kind of exercise that you all know. Here a proper stretch should be provided by the therapist to the psoas major muscle, hip flexors, just to keep the hip joint mobility. You should all note how the therapist you should all note how therapist is placing both of the hands. Again, isometric contraction over polymer ball. This is for bilateral amputees. She is doing bridging exercise. All these exercises will help in the later stages of rehabilitation because the bridging is very much important for the transfers. Active knee extension just to prevent the hip contractures. Sorry, hip extension. While raising the limb, this will also help in the lymphatic drainage because it will support the lymphatic drainage system. So we can evacuate the edema that is being collected in the distal part of the stump. Circumambulatory motions. Some static gluteal exercises. The patient will be placing a polymer ball in between both of the thighs and he will be actively contracting the conductor muscles as well as the gluteal muscles. Straight leg raises, again to support the lymphatic drainage system. Stump care. So we should ask the patient to keep the stump clean, dry, free from any infection. The prosthesis should be removed before going to the bed. The washing of the stump should be done with a mild soap, warm water every night, and it should be dried thoroughly and apply talcum powder. Do not use the prosthesis until the skin has been healed. The stump socks should be changed daily, and inside of the socket may be cleaned with a mild soap water every day. Here you can see why stump care and bandaging is important. In the picture A, you can see a bad bandaging technique is being used, the circular motions, and due to which in the picture B, you can see there is a bilateral asymmetry in both of the stumps. Also, there is a narrow band here. This is the choking of the stump, and because of that, there is a collection of edema in the distal part of the stump. This collection of edema might lead to infection, scar tissue healing problems. Also, it will provide a poor venous return towards the body. And this collected edema will contribute to the pain and finally into the delayed reaction part. So that is why a diagonal or oblique fashion of bandaging is being used, just to create a pressure in the distal part more tightly, and while moving towards the proximal part, we should keep the pressure a little lesser. Again, traditionally soft dressing and non-adhesive elastic bandages are used to prevent edema of the stump post-surgically, but very few evidence supports these bandages. So nowadays they are using post-surgical rigid or semi-rigid dressings to prevent acute edema that have gained a popularity in the world, and also it is supported by the literature although it is a very controversial topic nowadays, but we have seen due to the researches, it has been found that semi-rigid or rigid bandaging techniques have shown a shorter duration time for the scar tissue healing. Desensitization is a very much important part for these amputees. So patient can do this 2 to 3 times a day while using a soft material like a cotton ball over the surface of the stump, and start gently rubbing the skin in the circular motions. And he should progress by using a rougher material like paper towel, then progress to towel or a cloth until he can tolerate these materials. This will have a very great impact in the later stages that we will talk about. In the late post-operative physiotherapy, we have increased the resistance and repetition for all the exercises. Also, we have introduced a TheraBand over here on the thigh region, placing a pillow between the thighs. A TheraBand would provide a greater resistance just to train the gluteus medius muscle, the prime abductor. This will again help in the transverse part and the ambulatory part. As we have practiced desensitization of the stump, now the early graded weight bearing for these patients will be easy on a mattress. So he's practicing 4-point kneeling gait and moving on to 2-point kneeling gait. Then he can hold on to something, a static good structure like furniture, wheelchair, to get from the floor. And again. So here the patient is practicing this exercise just to keep the core muscle strengthening. Also the upper extremities is being used because we need upper extremity strength for ambulatory part like crutches and walker. As we have done with the desensitization part, so this will be easy for the patient to bear some weight on the stump. Some balance and coordination exercise. As we have practiced the 2-point and 4-point kneeling gait, so this will be easy for the patient to get from the floor towards the bed or even the wheelchair. As also we were practicing single leg balance in the early pre-operative stage. That is why patient is very much comfortable to get a weight on a single leg also. Here you can see. This is for bilateral amputees. That is why we were doing desensitization part in the early stage, so that they can bear some weight over the stump. As this wheelchair has a detachable armrest, but in India this is not that much common. So what we can do, we can place a plinth or a board from the wheelchair towards the bed, so the patient can slide. Again, the single leg standing was practiced earlier. That is why he is able to transfer from the wheelchair towards the bed. This is very much common position for the below knee amputees, to place the wheelchair just behind the bed area. So we were done with the desensitization part. That is why patient is now able to put a gradual weight bearing on this stump. The patient is holding a parallel bar that is very much easily available in the physiopedies. He is holding with the upper extremities. We have also trained upper extremities in the previous slides as we have saw. So he can now hold on to the parallel bars for the early graded weight bearing, and he can now progress towards a single hand support on the parallel bar, and then gradually moving towards the incline or decline walking without the support of the hand. Then, as we were practicing the upper limb strengthening exercises, this holding the cane or holding a walker or a crutch will be very much easier. Then we will train them for how to descend or ascend the stairs with a prosthesis and without prosthesis. And we were talking about 5 to 10 degrees of slight flexion contraction. If there will be a flexion contraction, the center of gravity will shift anteriorly, and that is why they will have a problem in upright standing. So that is why it is important to treat the flexion contracture priorly. So thank you. That is from my.
Good afternoon, everyone, senior dignitaries, senior faculty, my colleagues and juniors. So I'll be discussing here regarding advancements in amputations. And since phantom limb seems to be famous here, I'll be discussing my advancement regarding these two complications and how to tackle them. What are the surgical techniques in which we can tackle them? First, we need to understand what these complications are. The first is the residual limb pain, and the next is the phantom limb pain. So, what exactly is residual limb pain? Residual limb pain is the pain at the site of amputation or the pain in the stump. This mainly happens because of in presence of inflammation, infection, heterotopic ossification or neuroma formation. The initial three are more or less direct and self-understood, but why this neuroma formation causes pain in the residual limb? So what exactly is this neuroma? So when we transect the nerve, the regenerating nerves which cannot reinnervate the end target, they forms a neuroma bulb. This neuroma bulb consists of aberrant free axons, fibrotic tissue and blood vessels. Now these free axons are present anywhere else also in our bodies, for example skin, but they do not cause pain. So what is special about this neuroma bulb? The problem with this neuroma bulb is they have a very low threshold for activation, which results in increased neuronal activity and hypersensitivity. Now why do they have this low threshold? Now that is again because they have increased sodium channels in them. So another reason why this neuroma bulb causes the pain in the residual limb is they release cytokines, inflammatory cytokines by themselves, which again causes amplification and perpetuation of the pain in the residual limb pain. So this is the regarding residual limb pain. The next complication, which is a bit more tricky, is the phantom limb pain. Now this is the pain which is perceived in the missing limb or the amputated limb. The exact etiology of this is still not understood, but it is considered to be multifactorial. And both CNS, central nervous system, as well as peripheral nervous system play a part in this. If we come to central nervous system, what happens there is a process called as thalamic reorganization. In this, the area of the cortex, which represents the amputated part, they get taken over by the neighboring parts. So any stimulus if given in the neighboring part itself also creates a sensation in the missing part. Now this happens in both primary somatosensory as well as the motor cortex. If we come to the PNS part, as we already discussed, the neuroma bulb is already formed in the residual limb. They themselves are releasing abnormal spontaneous axonal activity, which is an inflammatory cytokines. Another reason what happens in the spinal cord is because the stimulus is less from the missing limb, the receptors for that limb increases. Also the inhibitory activity from the supraspinal center decreases. So a combination of this also creates phantom limb sensation. Another important reason is the psychological components which are associated with amputation. So if the patient has depression, anxiety or increased stress, this also causes thalamic reorganization and increased phantom limb. So these are the complications which we need to tackle in amputation. So these are the two new techniques called the neuromuscular surgical techniques. The first is a targeted muscle reinnervation and the next is the regenerative peripheral nerve interface. Now these two techniques were initially designed to have an advanced neural interface for prosthetic devices. But later on it was found that they can also have a function in neuroma control. So what are these two techniques? The basic working principle of these two techniques. You can see two similar looking designs here, but in both these two diagrams, the A and the B part is same. The A represents the muscle. This is the muscle, this is the motor nerve, and this is the bypassing mixed nerve in both diagrams. In B represents during the amputation, the muscle is cut and the mixed nerve is cut, the motor nerve is intact. Now what differs in targeted muscle reinnervation is the C part, in which it's not clearly visible here, but the motor nerve is cut, the transected, and the muscle is completely denervated. And now the bypassing mixed nerve is connected to that motor nerve, and the denervation, the reinnervation of the muscle happens by the mixed nerve. If we come to regenerative peripheral nerve interface, what happens here is the A and the B is the same, but in C part, if the nerve is thick, we further dissect the nerve into its fascicles and isolate the fascicles. We harvest two free muscle skeletal grafts and then wrap those nerves in those skeletal muscle grafts. So how does this help in neuroma? So we provide a distal target to the transected axons to grow into, and that helps to prevent and treat neuromas and their painful sequelae. This is by the targeted muscle reinnervation. Remember the motor nerve was divided, so that nerve is when it is divided, it is transferred or mobilized proximally, or it can be buried there itself. The thing about motor nerve is, even though they have few sensory fibers, they do not form a symptomatic neuroma. Remember, formation of neuroma is a physiological thing, it's not a complication, but only when they cause pain, it is considered as a complication. So motor nerves do not cause a symptomatic neuroma. The severed mixed nerve after reinnervation can contract in response to neuronal control for the missing limb, and this part can be used in function of a prosthetic limb also, especially the advanced ones such as bionic limbs these days. Coming specifically to below knee amputation, the neuromas can be excised and the nerve are transferred to a more proximal motor points of the soleus and the gastrocnemius muscle. And the superficial nerve, superficial peroneal nerve, that can be transferred to the deep peroneal nerve, which is the motor nerve, after the motor nerve to the anterior tibialis has split off. The second part is the regenerative peripheral nerve interface. So a lot of the prosthetic limbs, they rely on surface EMGs to drive the prosthetic limb. But the problem with this surface EMG signals is they have poor interface and they have poor prosthetic performance, especially on uneven grounds or stair climbing, cycling, or any other activity other than walking on straight ground. So in contrast, it was noted that when the electrodes were placed in the muscle, not on the surface, in the muscle itself, they had a greater reliability, they had lesser impedance, they had greater resistance to fibrosis, and they had improved longevity. So this concept was taken in RPNI to create an interface of the peripheral nerve fascicles which were reinnervating the free muscle grafts that can be interrogated by the electrodes outside. So just to go through the procedure again, this is a thick nerve further divided into fascicles. The fascicles was taken in the centered over a muscle graft. The fascicle was sutured to the muscle and then the muscle was wrapped around the nerve. Here you can see an example of below knee where the sciatic nerve was taken and further divided into fascicles and wrapped around the muscle. So this RPNI can be performed anywhere when there is a peripheral nerve is transected and you cannot reapproximate the axons back to their native targets. So not just in amputation, even when there is a trauma or the nerve is transected and you cannot reapproximate the axons, this procedure can be done. So in this procedure, major peripheral nerves are isolated, marked and sharply transected during the amputation as in any amputation, but the thing which differs here is traction neurectomy is not performed because we do not want the nerve to retract back proximally. Okay. In general considerations for this procedures is if the grafts are too thick, they will undergo central necrosis. So the ideal size of the muscle graft mainly depends on the caliber of the peripheral nerve which we are treating. And for most of the peripheral nerve which have a diameter of roughly 5 to 10 mm, the grafts which are taken is usually 3 cm long, 2 cm wide and 0.5 cm thick. Coming specific to below knee, the free skeletal muscle grafts can be harvested from a healthy area which can be from the amputated limb itself or it can be taken from the isolated proximal thigh. Typically what we use is vastus lateralis. In below knee amputation, the RPNI should be performed for tibial, peroneal, sural and saphenous nerve at the time of below knee amputation, and these muscle grafts can further be used for driving the prosthetic limb. So summing up the benefits and the future of this technique, they demonstrate a significant reduction in the neuroma pain, phantom limb pain, and they have improved prosthetic experience and psychosocial well-being. They can be used to treat symptomatic mixed nerve or sensory nerve neuromas throughout the body and even in non-amputees. They create additional control sites, eliminating the need to switch the prosthesis between control modes while doing various functions with the prosthesis. And together with the advances in robotic technology, they will surely lead improved quality of life and functional outcome for individuals with upper limb as well as lower limb amputations. So this was regarding my talk. So just to discuss a short case which we did just 5 days back. So this was an 88-year-old female with a popliteal block in her left lower limb. As you can see, the ischemic limb, which cannot be revascularized, forms an ideal indication for amputation. So the patient was taken into OT and the incision levels were marked. You can see 2 incision lines here. This is the proximal one and the distal one. The proximal incision mark marks the area where the bone is cut, while the distal one marks the area where the skin and the muscles are dissected. The incision was taken. This is the proximal one, this is the distal one. And after soft tissue dissection is done around the bone, we pass a jiggly saw under the bone. This jiggly saw is a wire shaped, so wire like flexible saw which is used to cut the bone. This is how it cuts the bone. Once the bone is cut, next step comes isolation of the vessels as well as the nerves. So you can mark the vessels, or I can identify the vessels by being hollow. Okay, not clearly seen in this, but the structure in this is hollow. You can see space. Whereas if you see a nerve, this is a nerve, you can see it is more of a solid structure and you can see the fascicles inside it. The vessels are ligated at the point they are transected, but to transect a nerve, this is the procedure where you have to pull the nerve outside as much as possible and transect it as proximally as possible, so the neural end retracts proximally. Once the soft tissue dissection and everything is done, always remember to file the bone ends, sharp bone ends, by using a rasp. And once everything is done, we proceed towards the closure over corrugated DTs for any discharge to come outside. And once the OT is over, always ensure that a good post-operative dressing is done. As sir rightly said, prevention is better than cure. So this is done to prevent any contractures in the limb. The knee can be maintained in a straight position. It also ensures a rapid tissue healing and it gives adequate pain relief for the patient. Any questions?
Thank you so much, sir, for explaining us about the new advancement in the treatment for the residual limb pain and the phantom pain. Now, I would like to call Dr. Megha, Associate Professor, Mahatma Gandhi Physiotherapy College, and she'll be explaining us about the recent advancement in the physiotherapeutic management of below knee amputation.
Good afternoon, all the dignitaries, respected senior faculties and dear students. So today my topic is recent advances in the physiotherapy and management of the below knee amputation. So the recent advancement includes the 3 T's, which is technology, training and team. So technology, as you all know, is the innovation, the advancement in the prosthetic level, which is a power control prosthesis, which are biocompatibility. Training, including the physiotherapy management already being discussed, but still the physiotherapy has a lot more to do in the advancement in the prosthetic management, having a specific guidance with the exercises and activation of the muscles with the gait training and reducing the energy expenditure, which leads to the endurance training of the amputees. Team, so definitely without a team management, the rehabilitation is not possible, which includes orthopedicians, physical therapists, prosthetics, orthotists and occupational therapists, and no doubt the psychological counseling is no doubt required in the amputee patients. So there are some of the benefits of the physiotherapy in the below knee amputation. That is, the physiotherapists teach how to walk with the prosthesis, a very important part after the support surgical. Then building the fitness level and the strength, and then to how to overcome the everyday obstacle. It is not about just walking, sitting and standing. It is about stair climbing. It is going from doors, outside the uneven surfaces. And the important part of the rehabilitation and the physiotherapy is returning to the work. So here are some of the latest advancements in the prosthesis in the below knee. These are the microprocessor knee joints. They have the sensors and the chip which gives you a natural gait. So in this you have a different modes which allow you to walk over the uneven surfaces, and it helps over the stair climbing as it reduces the ground reaction forces. Then these are again some of the pictures showing the microprocessor joints and the feet. So the microprocessor feet is a low maintenance and lightweight processor, and it is helpful in the especially in the patient who wants to go into the sports activity. So they have the specific recreation processes made for this, like running, cycling and skiing. Then we have again one level of the latest advancement, that is a bionic limb. With the motor control, it also provides with the sensory integration and the feedback, and thus it helps the patient and reduces the risk of the falling and the overloading of both the limbs. So then we have a different prosthetic legs for the different activities, in which the latest is the rush feet, and in this a fiberglass material is being used, so it reduces the lacking of the gait cycle to the sequence of these steps. So as in the first picture, we can see that the amputee is walking over the sand. So this is a new prosthesis design. It is also called as a cheetah prosthesis, which is useful for the amputee walking over the sand. It is a C-curve prosthesis. The another picture is depicting that a bilateral transtibial amputee is preparing for the Olympic swimming competition. So here some of the sports activity in which the amputee, the recent advances in the processes can help an amputee. So the first picture is showing using a straight pylons, which can use in the water sports activities. Then we have some prosthetic feet, which helps the amputee in the running and in the sprinting activities. So next is the recent advancement for the gait training, in which we have the vibrotactile biofeedback system. So as we all know, tactile means the touch sensation. So biofeedback machine with the virtual reality, some video games or a wearable biofeedback devices can be used to improve the gait and the mobility challenges. So the main challenge after wearing a prosthesis is the walking pattern. So there should be a smooth walking pattern. So as the amputee starts walking, he has to face a ground reaction force which doesn't lead him to a very smooth swing and a stance pace. So with this biofeedback system, these things can be changed. So then another, we have computer assisted rehabilitation environment. So this is a device in which a virtual environment is given to the patient, and the patient walks over the treadmill and is having a gait training as compared to what he will walk over the ground walking. Then we have a treadmill versus an overground walking. So it is being shown through the latest researchers that the treadmill walking is definitely helping the patient, because it is reducing the dorsiflexion and the knee extensor movement and helping the hip extensor movement. So it is helping the movement angles in the gait training, and it is improving the spatial parameters in the stance and the sink space of the amputees. So then another latest advancement is the load cell data supported of the processes. As in the earlier slides we have seen, there are microprocessors. With this they have a sensory control, and these processes help in the patient for the directional changes, that is quick running, quick directional changes, and walking over the uneven surfaces. Then we have a control electrical signal. Again, this is a latest development. In this, there is a sensory device which is being put in the processes, which gives the signals to the brain for the cortical remapping, that how the patient has to walk, and then it also helps in reduce the phantom limb pain. So now, as discussed as being discussed, Dr. Karthik has given a good explanation what is a phantom pain. But when you talk about the phantom pain in layman language, you can say the patient feels the pain in the body which is no longer he has. As the limb is being amputated, but still he feels that the limb is there. That is called as the phantom pain. So there are some of the recent advances which shows that you can reduce the phantom pain, and one is the first one is the repeated translinear magnetic stimulation. So this is a device or a coil which is put over the patient's brain, and it gives cortical stimulus to the brain, and works on the postsynaptic inhibition. That means two types of the pains can be inhibited. One you have already studied in your coursework, that is we have a presynaptic pain inhibition and a postsynaptic. So this activates the thalamus tract, and it works on the postsynaptic inhibition of the pain. So this is a biofeedback robotic setup through which you can give the transcranial magnetic stimulation. Then we have imaginary phantom limb exercises. So these exercises are basically the exercises the patient perform over the amputated limb, but this is being as an imaginary sense. The patient is performing a regular physiotherapy exercises over the amputated limb, and the cortical sensations are going to the brain to activate these muscles and making the patient aware that the limb what is moving is not an imaginary but his own part of the body. So then we have a mirror therapy as being discussed. So this is a visual feedback. This mirror therapy also gives you a visual and the tactile sensory inputs. As being said that you can see the amputated limb is being seen in the mirror and patient has awareness that he has a limb present. Then we have some of the instrumentations which is the virtual and the augmented reality. These are some of the gears which can be used for in the biofeedback machines. Then there is eye movement desensitization and reprocessing. Basically, it is used for the psychological counseling of the patient. There are the picture is showing that there are the 8 stages of this therapy. In this, all the negative emotions are being implemented and then they are being converted into the positive emotions so that the patient can forget that what trauma he has gone through. Then TENS, the electrical therapeutic modality. So recent studies have shown that a low TENS for 30 to 40 minutes had helped the patient in reducing the phantom limb pain at a very effective way. Then we have the hydrotherapy units, and definitely these are helping the amputees, the most recent advancement. So for this the therapist has to be specialized in the water properties, and it helps the patient both physiologically and psychologically. So there are some of the advanced exercises as the PT part has already been covered and you have seen that what are the basic exercises which is required for the amputation. But some of the strengthening exercises are going to definitely help the patient to regain to the work. So on this you have to concentrate on your back and your abdominal muscles, that is your core strengthening. So for those you have the ball exercises. As you can see, the patient wearing a prosthesis sitting on a ball and he can do the reaching activities. The second picture is showing the planks. Then you have a seated push-up. This is a very good exercises. This will again increase the tone of the core muscles, and these seated push-ups also helps the patient more of the shifting, like how to stand from a chair, how to get down on a chair, how to shift from one chair or a wheelchair to a chair. Then we have single leg squats. This is again one of the very important exercises which allows the patient to go from a standing to a sitting and to a lower surface level sitting. Then we have a bouncing ball exercises. Now these exercises are very important when you talk about the spatial. When the patient has to change the direction, he has to be more concentrated. So these exercises help with the coordination and the concentration. Then balancing a stick, again it works with the coordination and the concentration exercises. Then balancing on the prosthesis, a very important part, because when the patient will start standing, walking and sitting, the loading over both the limbs should be equal. So the balancing on the prosthesis is a very important part of the exercise. Then walking on an uneven surface, it helps in the gait training. Then jumping, so these jumping exercises are only for the below knee amputation so that they can balance the weight on both the limbs. Then we have running. So running can be induced in the amputees who want to regain to the sports activities. And then we have the agility and the balance training, which is a very important part because it accelerates and maintains the motor control, and it helps the patient to change the directional changes, whether it is a vertical or a horizontal direction. So in the first picture you can see that there are small cones and the patient is trying to do a hurdle walking. In the second picture, there is a squeezing of the ball to improve the proprioception, and third is the TheraBand exercises. So, being a physiotherapist, we keep you moving, and this is a picture showing a Paralympic athlete who won 3 gold medals.